Hello, welcome to Pathagonia. This is Jay. Today we're going to use excellent Kurt's notes to talk about a variety of breast lesions, but can be grouped as spindle cell lesions, where we'll talk about PASH, myofibroblastoma, desmoid fibromatosis, then metaplastic carcinoma, invasive breast cancers with either or both and an epithelial or mesenchymal differentiation, followed by vascular tumors of the breast and a biphasic tumor that's analogous to the salivary tumor called epithelial myoepithelial carcinoma. So let's get to the spindle cell lesions. PASH, otherwise known as pseudoangiomatous stromal hyperplasia, it's characterized by these myofibroblasts, an increased number of them, as well as this background thick collagenous stroma. And then you'll have these like slit-like channels that look like vessels, but you won't see any red blood cells in them. You won't see any endothelial cells because they're not true vessels, hence the name pseudoangiomatous. And then with that background collagen and proliferation of myofibroblasts, you'll have the stromal overgrowth, hence PASH. It's not neoplastic, and sometimes it could be an incidental mass-forming lesion. I remember a breast biopsy case, where they saw a mass, and in the biopsy we didn't see anything except for PASH in that case. PASH is benign and needs no treatment. All right, myofibroblastoma. This is a purely mesenchymal tumor composed of mammary stroma made by fibroblasts and myofibroblasts. Clinically, it's a slow-growing, painless mass and is cured by local excision. Histologically, it'll be this well-circumscribed, unencapsulated mass with these. This is your kind of great descriptor for myofibroblastoma. Thick collagen bundles, as you can see here. And interspersed amongst these thick collagen bundles, you'll have these bland spindle cells with minimal atypia. They'll have these short, haphazardly intersecting fascicles. And to help you on immunohistochemistry, these just stand for Desmond, CD34, ER, PR, AR. And you can send for FISH, where it's one of those entities that has the RB1 deletion, and it'll be 13q14 deletion. All right, desmoid fibromatosis. So this is a benign but locally aggressive tumor because there's a strong tendency to recur, greater than 25%. Of interest, if you excise it and there are positive microscopic margins, that does not necessarily predict recurrence. Histologically, you'll have these kind of broad sweeping fascicles infiltrating growth into surrounding structures like skeletal muscle, like breast tissue, and these spindle cells are pretty they're not very atypical. They're small, they have pale nuclei, just pinpoint nucleoli. They have moderate amounts of collagen with slightly myxoid background. And if you're unsure, you could order a beta-catenin, and the aberrant staining pattern will be nuclear staining. And that's partially is because of the molecular pathway. It's associated with the FAP mutations in the APC/beta-catenin pathway. All right, let's switch gears and talk about metaplastic carcinoma. So these are pretty rare. They represent less than 1% of all breast cancers. And within metaplastic carcinoma, there are several distinct patterns. So low-grade adenosquamous carcinoma will have these glands and tubules, and they're associated with kind of a desmoplastic stroma, as you can see here. Sometimes it can also be associated with cannonball lymphoid aggregates, and this is a relatively good prognosis. Now, we just talked about desmoid fibromatosis, so some of the histologic features of those overlap with this fibromatosis like metaplastic carcinoma. They'll have these bland spindle cells with pale eosinophilic cytoplasm and slender nuclei and stroma. You can have variable amounts of collagen. There's only mild nuclear atypia, and it's often arranged in fascicles. This also has a good prognosis. Then you have your spindle cell carcinoma. And spindle cell carcinomas can have a wide variety of architecture, including fascicles, herringbone. They can be plump and or kind of elongate, and they can have moderate to high cytologic atypia. It includes a spectrum of tumors from sarcomatoid spindle cell carcinoma to myoepithelial carcinoma, and this has a worse prognosis. So squamous cell carcinoma, you can have pure squamous cell carcinoma. It's often cystic, and you must exclude a metastasis, and also has a worse prognosis. All right. Metaplastic carcinoma with heterologous mesenchymal differentiation, essentially a carcinosarcoma. You'll have heterologous elements that include chondroid, osseous, and rhabdoid components. And either or both end, the epithelial and mesenchymal components can have variable atypia. And if you're the grosser on a mastectomy and you're suspecting this, you might have to put in a lot of sections to find the epithelial component. Otherwise, you think of more of a primary sarcoma. Immunohistochemically, vast majorities do not express, they're triple negative, ER/PR HER2 negative. They do metaplastic carcinomas express some epithelial markers, high molecular weight cytokeratins like CK56, be positive for P63, negative for CK7, CD34. And molecularly, there's often a frequent TP53, PIK3CA, and WNT pathway mutations. Clinically, there is much fewer lymph node metastasis. All right. That was a big one. Thanks for staying with me. Let's talk about vascular lesions, hemangiomas. These are benign proliferation of mature blood vessels. They'll be often well circumscribed, often found on imaging, not through clinical exam. And you can have vessels of varying sizes. They're often non-anastomosing. They should not have nuclear atypia. And you don't necessarily need excision. All right, now let's talk about the more scary lesions, atypical vascular lesion and angiosarcoma. So atypical vascular lesion is benign. It's often found in irradiated skin. For instance, if a patient had lumpectomy and they needed radiation, or mastectomy and needed radiation, you might suspect an atypical vascular lesion if you see with that history. You'll see these irregularly shaped thin-walled vessels with branching and anastomosing growth. They have a single layer of endothelium with some hobnailing and some hyperplasia. There should be no endothelial cell multilayering or true cytologic atypia. And if you're confused if it's a atypical vascular lesion of the breast or post-radiation angiosarcoma, you can order a MIC test, and there should be no MIC overexpression in atypical vascular lesion. All right, angiosarcoma. These are very, very aggressive, have poor prognosis. You can have two types, generally two to three types of angiosarcoma. One is an older gentleman who has a lot of sun exposure on his head. The second type is patient who's had radiation of the breast. And the third type is patient who's had a mastectomy and an axillary lymph node dissection. And then from chronic lymphedema, you get angiosarcoma. It's called like Stewart-Travis syndrome. Okay, let's talk about just angiosarcoma in general. You'll have varying degrees of vascular differentiation. Some areas show well-formed anastomosing vessels, while others may show solid sheets of high-grade cells. They can be spindled, but they can also be epithelioid, and you'll see a lot of hemorrhage. In contrast to your hemangiomas, they'll have significant cytologic atypia, as you can see here with the different in size compared to this cell. The endothelial cells will be piling up, and you might see mitotic figures as well. This could be a mitotic figure. Some layering up as well. Grade does not predict prognosis because if you have an angiosarcoma, it's going to be aggressive. Post-radiation angiosarcoma occurs after radiation, usually around 5 years, and this one will have a MYC amplification, as you can determine by IHC or FISH. Your adenomyoepithelioma is a biphasic tumor. It's analogous to your salivary epithelial myoepithelial carcinoma. Basically, it's a proliferation of your inner ductal cells and outer myoepithelial cells. There are various patterns, but can be tubular with prominent myoepithelial cells with clear cytoplasm, as you can see here. These clear cells are the myoepithelial cells, and here the ductal epithelium. Or they can have more spindled myoeps, as you can see here, with admixed ducts. Clinically, you'll see these in older women with a palpable mass, usually benign, but you have to be careful because it can de-differentiate into a carcinoma. Molecularly frequently driven by PIK3CA, ATK1, and HRAS mutations. Whew. All right, so just last things to cover up, other lesions that we did not talk about. A nodular fasciitis, that's your kind of tissue culture looking entity. Inflammatory myofibroblastic tumor, that's often spindle cell tumor with a lot of background inflammation interspersed. You want to get an ALK. Schwannoma are well encapsulated. You'll have Verrucae A, Verrucae B, Antoni A, Antoni B bodies, and within Antoni A, you'll have your Verrucae bodies, or you'll have Verrucae regions. Neurofibroma, you can have your granular cell tumors. Look for that pustulal ovoid bodies of Milan in the cells themselves. Leiomyoma, leiomyosarcoma, lipoma, angiolipoma, and liposarcoma. All right, so here's a great chart for your review. Just due to time, we won't be going over this, but hopefully you learned something from this video or reviewed something from this video, and thank you so much for watching.